residency in internal medicine here at Yale, and then subsequently stayed for his cardiology fellowship. His career interests are in cardiac intensive care and interventional cardiology, with a particular interest in the management of cardiogenic shock. During his training here at Yale, he had dedicated much of his time to outcomes research, with most of his work focused on improving patient outcomes within the cardiac intensive care unit, which has led to numerous publications in JACC Advances, the American Heart Journal, Journal of the American Heart Association, and JACC Heart Failure. Luckily for us, he will be staying here at Yale, and once he finishes general fellowship in June, he was able to specially craft his subspecialty training and will be completing advanced fellowships in both critical care and interventional cardiology over the next 2 years. Please join me in welcoming Alex, and now I'll let him take it away.
Thank you, Catherine. All right, hopefully everyone can hear me okay. So thank you for the opportunity to speak with you all today. Given my career interests, I wanted to talk to you all about today both the evolution that has occurred in the CCU that has led it to become the modern CICU that we know today, and also talk to you about the similar evolution that has occurred in cardiogenic shock care and how we are working to improve the care of cardiogenic shock patients here at Yale. I have no disclosures for this talk. So the CCU developed back in the pre-revascularization era, where the main cause of death for patients with acute myocardial infarction was ventricular arrhythmia and cardiac arrest during their that would occur during their index hospitalization. In the late 1950s and early 1960s, Dr. Desmond Julian in England witnessed significant variability in the care, in the timing and the quality of resuscitative care that post-AMI patients would receive in response to arrhythmic arrests. And he described how quick defibrillation and resuscitation of these patients at the time of these arrhythmic arrests would significantly improve their chances of survival. And with this observation, he first proposed the concept of the coronary care unit to improve the care and survival of patients post-AMI. And in this proposal to the British Medical Society in 1961, he described a single specialized unit in which there was specialized equipment and staff to care for these patients, which included continuous EKG monitoring and alarms that would trigger in the presence of arrhythmia, and staff that were especially trained to provide immediate defibrillation and high-quality CPR in response to these arrhythmic events. And Dr. Julian centered much of this care around nurses, who were always the first to the bedside, and he empowered them to be the ones to first initiate and perform these resuscitative efforts so that there was no delay in these patients' care. And this model worked very well, and more CCUs began to develop over the first decade or two. And the functions of the unit began to evolve in this time. And it came with the incorporation of newly developed technology, including echocardiography, the Swan-Ganz catheter, and the intra-aortic balloon pump. And with these new tools to evaluate and monitor patients in the CCU began admitting patients with suspected AMI, rather than just those that already were post-infarct. And there was a shift from resuscitation at the time of an arrest to more monitoring for signs of clinical change and in the prevention of arrhythmia and arrest. And over these 2 decades, there was rapid adoption of the development of CCUs across the US and internationally. And the CCUs made dramatic impacts on acute myocardial infarction outcomes and dramatically improved survival and shifted the major cause of death following AMI from that of fatal arrhythmias that would be occurring during their patient's index hospitalization to that of ventricular failure, which would now occur months or years down the road. And this improvement in outcomes was prominently acknowledged by Dr. Brunwald in a publication in The Lancet from 1998, where he wrote on the evolution of the management of acute myocardial infarction and stated that the coronary care unit was the single most important advancement that was made in the treatment of acute myocardial infarction. And since the 1980s, there's been a dramatic change in the CCU that has occurred, which has led to the transformation from the CCU to the modern day cardiac intensive care unit, which in a lot of ways now more closely resembles the medical ICUs. But this But the CCU is still comprised of patients with complex cardiovascular disease who require specialized personnel, therapies, and equipment for modern advanced cardiac care. And though there are many factors that have really contributed to this evolution, there are really two main ones that have led to its transformation. The first of which was a decline in the need for intensive care following acute myocardial infarction. And this was first observed by Dr. Katz at Duke in the late 2000s, when he noted that there was a decline in the prevalence of STEMI patients in the CCU. And he found that from 1989 to 2006, that the prevalence of STEMI patients in the CCU had in fact declined from 40% down to 20%. And much of this was attributable to advancements that had been made in coronary angioplasty, as well as the protocolization of STEMI care. But perhaps more important than just the decline that they had seen in STEMI patients in the CCU that led to its transformation was the general steady rise that they are seeing in medical complexity among patients with advanced cardiac conditions that are admitted to the CCU. And this is a result of the therapeutic advances that have been made across really all domains of cardiac care that are now allowing patients to live longer and to tolerate far more advanced and complex cardiac diseases. And partially as a result of this, patients are presenting significantly sicker than they had previously. And as an example of this, data shown here is from the National Inpatient Sample. And it shows that the rates of cardiogenic shock have over tripled since 2004 up until 2018, most of which has come in the form of shock that is unrelated to AMI. And there has also been in the CCU a significant change in the reason that patients are being admitted to the CCU, with data from the Cardiac Critical Care Trials Network, which is a collaborative research network of level 1 CICUs in North America, of which we've been a part of here at Yale since 2017 when they began data collection. And they were able to demonstrate that respiratory failure now was the #1 reason that patients were being admitted to the cardiac ICU. And with these increases that we're seeing in medical complexity have come also steadily rising rates of other intensive care therapies that are required. And we are now seeing that over 1/3 of patients that are admitted to the CICU require either non-invasive or invasive mechanical ventilation, that over 40% of patients in the CCU will require at a period of time either inotropes or vasopressors. And beyond this, an additional 10% will also require some form of mechanical circulatory support. Additionally, we're seeing that 8% of patients in the CCU require continuous renal replacement therapies, 4% are requiring target temperature management, and an additional 5 to 7% of patients are requiring other advanced ICU therapies. And as we have also recognized that patients come to the CI, and we are also recognizing that patients that come to the CICU have many more pre-existing non-cardiovascular comorbidities and conditions that affect their mortality. And we studied this here at Yale. Along with collaborators from Mayo, we examined data from patients that were admitted primarily between 2013 and 2017. And we found among our own CCU population that nearly 2/3 of patients who were admitted had at least one or more significant non-cardiovascular comorbidities, including chronic kidney disease, chronic lung disease, and chronic liver disease, as well as active cancer or diabetes. And that more than 10% of the CICU population now had 3 or more of these chronic conditions prior to their admission. And we also found, perhaps unsurprisingly, that patients with 1 or more of these non-cardiovascular comorbidities had increases in mortality. And that, in fact, mortality increased in a stepwise manner as the number of non-cardiovascular comorbidities increased, to the point where patients that had 3 or more non-cardiovascular comorbidities had nearly double the in-hospital mortality of those patients without any non-cardiovascular comorbidities who were admitted to the CICU. And along with this, we've also seen a rise in the rates of organ dysfunction in the CCU, with rates of non-cardiac organ failure nearly doubling from 2007 to 2018. And multi-organ failure is now being seen at rates of as high as 35% in CICU patients, compared to just 12% 10 years prior. And with this comes the obvious need to utilize more intensive therapies to treat these patients, which requires expertise and experience with these therapies, especially when multiple of them are being employed for a single patient. And these changes that I just mentioned have been occurring in the CCU or the CICU since the 1980s. They evolved relatively slowly and somewhat under the radar until the late 2000s, early 2010s, when clinicians began to formally identify and quantify the changes that we were seeing. And because nearly 30 years of increasing patient acuity, had built up somewhat behind the scenes, CCUs were in a way left struggling to keep up with these changes. And from this came, so to say, an alarm that CCU patients were no longer the past AMI patients which filled the original CCUs, and they now represent a medically complex, critically ill patient population that is not only increased in cardiac complexity, but also now frequently requires care more typically seen in the general medical ICU, and that modern CCUs need to be equipped to manage this population. And this was perhaps best summarized by Dr. Katz, who is one of the leaders in the field of cardiac critical care, in a perspective piece that he wrote back in 2007 in JACC entitled Cardiology in the Critical Care Crisis. And since this recognition, there has really been a reassessment of CICU care and how to meet the needs of these patients with advanced cardiovascular disease, which require now a multitude of additional intensive care therapies. And one of the first changes that hospitals began to make to address this evolution was the adjustment in how CICUs were being staffed by physicians. One of the first models was really to consolidate the staffing within the CCU by transitioning from a model that many CCUs had used in which multiple attendings would admit and manage patients within their subspecialties or because they were their patients, which was referred to as an open model, to a model that was more focused on one or two dedicated care teams, leading to the care of all the patients in the unit and referred to as a closed model. And this was done here at Yale at the end of 2015, when the CCU was transitioned from a model that saw up to 7 different attendings to a teams of now just 2, with an interventional team and an advanced heart failure team. And we looked retrospectively at patient outcomes in the year 2 years before and the 2 years after this transition occurred. And after adjustments, we found that there was a significant improvement in both CICU and in-hospital mortality associated with this transition. And we then looked closer at what populations within the CCU most benefited. And we found that it was those with respiratory failure and those who were post-cardiac arrest, which were among the populations that have some of the greatest needs for additional intensive care therapies. But we also found that really nearly all the populations that we looked at demonstrated at least some trend towards improved mortality. And subsequently, hospitals have been further evolving with greater emphasis being placed on the critical care needs of patients and how to best provide these therapies. And this brought about some additional staffing models to the CCU, which included a co-management model whereby a cardiologist would co-manage the unit with another intensivist, either a medical ICU doctor or a critical care anesthesiologist. And they similarly in studies have demonstrated that there are lower rates of CICU and hospital mortality associated with this transition, and also have shown that there is at times shorter lengths of stays and shorter durations of mechanical ventilation. But most recently, most level 1 or tertiary care CICUs have begun transitioning to a staffing model where it's focused on mainly dual-trained cardiac intensivists, who are cardiologists who have completed fellowships in both at least general cardiology and critical care. And they've done this to further improve CICU patient care, as was seen and demonstrated in the study here by Na et al., where they saw a near 50% reduction in both cardiac and non-cardiac mortality by transitioning to a model focused on the use of cardiac intensivists staffing the CICU. And likely, this results from critical care cardiologists having the foundation of cardiology training to manage complex cardiac diseases, but also the skills to manage other aspects of critical illness, including advanced ventilatory management, management of neurologic emergencies, and multi-system organ failure, as well as having the ability to urgently perform bedside procedures, such as endotracheal intubation, bronchoscopy, and the placement of chest tubes, which are now not infrequently required in the modern cardiac intensive care units, and which up until recently were skills that the current CICU attendings, including many of the pioneers of the field of cardiac critical care, were left to acquire on their own and independently. And as an intern myself in the CCU here, coming in with a great interest in cardiology and also in critical care, and having developed a deep fascination in that first year already in the management of cardiogenic shock, upon learning that this field existed, it became very clear to me immediately that this was the field that I wanted to pursue for my career and to pursue both clinically and academically. But as I spent more time in the CCU as a resident and as a fellow, and I saw more and more patients with cardiogenic shock and witnessed firsthand their high mortality, despite us doing seemingly everything that we could to try and keep them alive, I realized that the full spectrum of cardiogenic shock care really extends well beyond the CICU and requires the skills and expertise of many, including interventional cardiologists, advanced heart failure physicians, and cardiac surgeons, just to name a few. And I really wanted to improve the care of these cardiogenic shock patients and realized that in order to do so, it would take much more than just improving their care within the CICU. And this was very clearly illustrated to me firsthand by the work that we had done looking at outcomes among CICU subpopulations when the CCU here had transitioned from an open to a closed unit. And we saw across all subspecialties or subpopulations that we looked at that there was nearly a universal improvement in mortality. However, those with cardiogenic shock alone showed no improvement in mortality. And though since the 1970s, there has been significant improvements made in cardiogenic shock care, namely for those with AMI-driven cardiogenic shock, which occurred following the broad adoption of primary PCI for acute coronary syndromes in the 1990s, as well as subsequently when the shock trial demonstrated improved mortality with urgent vascularization of AMI-induced cardiogenic shock in the 1990s. But since then, and really for the last 15 to 20 years, there has been minimal improvements made in cardiogenic shock outcomes amongst both the AMI and non-AMI populations. And though the mortality is slowly creeping in the right direction, it remains unacceptably high, with in-hospital mortality rates as high as ranging typically between 30 and 40% based on most large-scale registries, including the data I'm showing here that comes from the National Inpatient Sample that shows really since at least 2007, 2008, that mortality for AMI or for all cardiogenic shock patients has remained between 30 and 40%. All the way up until 2018. And on top of this, we're also seeing that the rates of cardiogenic shock are continuing to rise and have nearly quadrupled since 2004. And because of this, there has been an immense focus on improving the care of these patients over the past 2 decades. And this has led to significant advancements made in therapies designed specifically to treat these patients, including a multitude of device options for mechanical circulatory support, which were designed to improve cardiac output while overcoming the limitations of vasopressors and inotropes, which can lead to fatal arrhythmias and other complications. However, so far, from the few randomized studies that we do have that are looking at mechanical support devices, they have not shown that there have been significant improvements in outcomes made when using MCS in a broad and generalized manner. In the first large randomized trial, which many of you are likely very familiar with, the IABP SHOCK 2 trial, showed that there was no improvement in mortality with the routine use of a balloon pump among patients, among sort of a generalized population of AMI cardiogenic shock patients. And since then, there have been multiple other smaller pilot type studies, which were randomized, but only comprised of 50 or fewer patients, which have looked at other more advanced forms of MCS and have not shown any significant signal for improvement in mortality compared to the intra-aortic balloon pump when they're used in a generalized manner. And most recently, we have the ECMO cardiogenic shock trial that was published just in the last 6 months. And it looked at 117 patients that had rapidly deteriorating shock and found that immediate VA ECMO did not improve mortality compared to the alternative shock therapies, which included combinations of pressors, inotropes, and other MCS devices. And though this study did have significant limitations, including a 40% rate of crossover to VA ECMO, it did show something notably, that there was at least no increase in harm with the immediate deployment of ECMO for advanced cardiogenic shock. And it showed that there were no differences in adverse events, including stroke, leg ischemia, and bleeding. But this slide is really not intended to say that mechanical circulatory support is not the answer for these patients, as it provides major improvements in cardiac output, which are absolutely essential for keeping these patients alive. But rather, the studies in this slide demonstrate that the utilization of mechanical circulatory support in a broad, generalized manner among patients with cardiogenic shock is likely not going to provide improvements in cardiogenic shock mortality alone when used in a generalized manner. And this led many to take a step back and look more at the whole population of cardiogenic shock, rather than looking at purely as a patient that has a problem with their pump. And with this, it was recognized that similar to what was seen in the CICU population, the cardiogenic shock population was also had significantly increased non-cardiovascular comorbidities and had increased significantly in both cardiac and non-cardiac complexity. As patients now are seen with numerous non-cardiovascular comorbidities, which significantly impacts their mortality. And we demonstrated this from our own research at Yale, where we see that mortality increases in a very stepwise manner as the number of pre-existing non-cardiovascular comorbidities increases in patients that have cardiogenic shock. Further, the cardiogenic shock population as a whole has changed significantly in its makeup. It has shifted away from ACS being the primary cause. And though the proportions of patients with AMI-driven cardiogenic shock are numerically on the rise, the proportion of patients with AMI shock has declined from 50% to now 25% of the cardiogenic shock population in the past 2 decades. And additionally, it was also recognized that there is an increasing number of phenotypes and subphenotypes among these cardiogenic shock patients, which have very significant implications for their care. And while how we phenotype patients with cardiogenic shock into the classic buckets of having acute myocardial infarction, acute on chronic heart failure, and acute de novo heart failure, as well as how we're assessing their hemodynamics to determine if there is isolated left ventricular dysfunction, isolated right ventricular dysfunction, or right ventricular failure, has largely remained unchanged. We're now realizing that there is a whole multitude of other phenotypes within these categories, which are critically important to identify, as they can significantly impact treatment options, as well as responses to certain therapies and the chances of patients having cardiac recovery. And these include, but are not limited to, patients with severe valvular disease, patients with COVID or other virally driven myocarditis, patients with peripartum cardiomyopathy, with SCAD, patients that have stress cardiomyopathies, patients with tamponade or other pericardial diseases, patients that have high rates of arrhythmia, patients with complex coronary disease, patients with acute heart transplant rejection, patients with immune checkpoint inhibitor myocarditis, patients with complications of acute MI, patients with pulmonary hypertension, with pulmonary emboli, and patients who are post-cardiac arrest. In mixed cardiogenic shock, which is now an increasingly recognized entity in which patients with both low cardiac index and low SVRs, hence having a vasodilatory component to their shock that's not otherwise attributable to sepsis, is being an increasingly recognized form of cardiogenic shock, which may comprise up to 20% of cardiogenic shock patients and has notably higher mortality. And along with improving the phenotyping of cardiogenic shock, there's been a great deal of focus now made on the additional characterization of cardiogenic shock by including the evaluation and identification of risk modifiers, such as patients who have brain injury following cardiac arrest, patients with multi-organ dysfunction, patients with peripheral vascular disease, and who are presenting also with severe hypoxia, as well as defining cardiogenic shock severity, which up until recently, cardiogenic shock severity has not been assessed in a universally consistent manner across different health systems and hospitals. And this is really due to the lack of having a staging system, which led in 2019 to the development of the SCAI shock stages. And after their initial development, they were extensively validated across multiple different populations in the following years. And this led to mild revisions and led to the SCAI shock staging system that we have today that was recently published in 2021. And this stratifies patients with cardiogenic shock into 5 main groups: patients that are at risk, who have experienced a significant cardiac event, such as coming in with acute decompensated heart failure, who have had a large infarction, but are not experiencing currently hemodynamic symptoms or signs of cardiogenic shock. Then there's the patients in stage B, patients that have clinical evidence of hemodynamic instability, including having hypotension, tachycardia, or other hemodynamic markers of cardiogenic shock, but are not showing evidence of hypoperfusion. Then there's stage C, patients that are sort of the classic ones that you think of, those that have hypoperfusion, mildly elevated lactates, decreasing urine outputs. And these patients are those that begin to require pharmacological therapy and mechanical circulatory support. And then there's the deteriorating patients, the stage D patients, who are showing clinical evidence of shock that is continuing to worsen despite escalation of therapies. And then finally, stage E patients, which have refractory shock and are impending circulatory collapse. And now, with this staging system, it provides a universal means not only of staging shock severity, but also in communicating the severity of a patient's cardiogenic shock to other providers. And perhaps more importantly, it also allows one to better trend a patient's evolution after they initially presented with cardiogenic shock, and allows the assessment of response to therapies and helps to inform whether the patient is improving or whether they are worsening and are going to require an escalation of support. So now, how do we improve the care of this growing population of cardiogenic shock patients, which requires quick intervention to prevent permanent end organ damage, and that has grown in both cardiac and non-cardiac complexity, such that no single physician could reasonably expect to have all of the expertise to manage all aspects of these patients' care, and for which there now exists a multitude of medical and device therapies, but without high-quality data to draw upon to create specific treatment algorithms. And this question led to the development of multidisciplinary cardiogenic shock teams, which bring together the unique experience, expertise, and overlapping skill sets from critical care cardiologists, interventional cardiologists, advanced heart failure physicians, and cardiac surgeons to help facilitate the early assessments and management of these critically ill patients. And to date, there have been a few studies which have looked in an observational manner at the impact of these teams, and thus far have shown very promising results. The first study, which was published by Tarani et al. Back in 2019, where following the implementation of a cardiogenic shock team, they found that 30-day survival increased from being 47% to 58% in the first year following this team's establishment, and then further increased to 77% in the subsequent year. And similarly, Talib et al. Published in Circulation, also in 2019, on their experiences from a single center in Utah, looking at patients with cardiogenic shock that were refractory to vasopressors, and found that the implementation of a cardiogenic shock team resulted in significant improvements in both in-hospital and 30-day mortality when comparing groups of approximately 120 patients that were admitted before and after the implementation of a cardiogenic shock team. And then also in 2019, Basir et al. Reported outcomes from the National Cardiogenic Shock Initiative, which utilized a very specific protocol where MCS was deployed primarily before PCI in patients coming in with AMI-driven cardiogenic shock. And they were able to demonstrate that with this protocol, they were able to reduce in-hospital mortality of cardiogenic shock patients down to 28%. And most recently, we have a study from the Cardiac Critical Care Trials Network that was published in JACC in 2021 that utilized data from more than 1,200 patients with cardiogenic shock from over 24 centers. And they compared outcomes among patients who were treated at centers with cardiogenic shock teams and those without cardiogenic shock teams. And they notably found that there was a significant reduction in CICU mortality associated with the use of these cardiogenic shock teams. And they further found that centers that had cardiogenic shock teams had significant differences in care practices, with shock team centers having significantly higher rates of PA catheterization usage and overall, interestingly, less use of mechanical circulatory support, with patients treated at shock team centers receiving mechanical circulatory support only approximately 35% of the time, whereas centers that did not have shock teams utilized mechanical circulatory support in approximately 43% of their shock patients. But importantly, the study also showed that shock team centers, when they chose to utilize mechanical circulatory support, they often more frequently went to advanced forms of MCS, meaning devices that provide more support than just a balloon pump. In this study, they also found that shock team centers were faster to insert PA catheters, with time to PA catheter insertion in the shock team centers being less than half that observed in centers that did not have shock teams. And they also went beyond just looking at lower mortality and mortality outcomes and found that centers with shock teams also demonstrated improvements in having lower rates of patients that required mechanical ventilation, in having lower rates of patients that required new renal replacement therapies. And they also demonstrated that they were able to achieve or showed association with shorter ICU length of stays. And as a result of these studies, we've now seen an evolution occur in cardiogenic shock guidelines with regards to recommendations that are made for cardiogenic shock teams. In fact, the first guideline, at least that I was able to find, that even provided a recommendation for a shock team came in 2017 when the AHA made a scientific statement on the contemporary management of cardiogenic shock and noted that a multidisciplinary cardiogenic shock team should be considered for the coordination and delivery of care for these patients. And though they did mention that at the time there was no current data to support this recommendation. Then, following the 3 observational studies that were published in 2019 that we went through, a 2020 ECS position statement on AMI cardiogenic shock noted that a standardized team-based approach may improve outcomes for patients that have cardiogenic shock. And then in 2021, the European Society of Cardiology heart failure guidelines also noted that unselected use of patients with mechanical circulatory support for cardiogenic shock was not supported, and that rather the choice of using MCS requires specialized multidisciplinary expertise. Then in 2021, the AHA made a statement on AMI complicated by cardiogenic shock. And they noted in this that multidisciplinary teams were recommended to coordinate the early assessment, device selection, and optimization of care for patients that had AMI cardiogenic shock. And now in the past year, we've seen that societal guidelines have actually gone on to give class level recommendations, with the 2022 AHA heart failure guidelines giving a class 2A recommendation that a multidisciplinary shock team should be considered in the should be utilized in the management of patients that have cardiogenic shock. And most recently, in February of this year, the International Society for Heart and Lung Transplantation and the Heart Failure Society for America wrote guidelines on acute mechanical circulatory support and made a class 1 recommendation that a multidisciplinary evaluation by a shock team should be used in the assessment of cardiogenic shock and in helping to determine the need for and the selection of mechanical circulatory support devices. And now I want to share briefly with you some work that we've been doing here at Yale, working to build a cardiogenic shock team to improve the outcomes for our patients who develop cardiogenic shock. So we began as a working group that was comprised of members from interventional cardiology, advanced heart failure, cardiac critical care, cardiothoracic surgery, and the cardiac ICU intensivists. And with this team, we discussed how to best create a shock team here at Yale, with the goal of developing a team that would expedite multidisciplinary discussions regarding the management of patients with cardiogenic shock and to help facilitate timely and appropriate interventions. And the team we developed is comprised of 5 specialties, from interventional cardiology, advanced heart failure, those in cardiac critical care, cardiac surgery, and the cardiothoracic ICU intensivists. which all provide specific expertise to address the most commonly encountered forms of cardiogenic shock. And though there are going to be many unique scenarios that will require additional expertise, such as with patients who have severe valvular or peripheral vascular disease, or who have complex congenital conditions, these 5 specialists collectively have the expertise necessary to assess and manage these patients when they are first identified with shock. And this team will be made up of providers from specialties, including that are using existing provider roles in which these providers are already seeing and managing patients with cardiogenic shock, but are left to do so in a much more individual manner. And the purpose of this team, in bringing this team together really, is to expedite the assessment of cardiogenic shock and to help identify the type of shock that patients are presenting with and whether or not there is a mixed or non-cardiogenic component or primary driving factor, to help in determining cardiogenic shock phenotypes, and not only just whether it's AMI, heart failure, or new heart failure, or helping to determine whether it's right ventricular, biventricular, or left ventricular only failure, but helping to identify these subphenotypes that we went through, and also identifying shock modifiers, which have significant impacts on the treatment algorithms or the treatment processes that we may pursue for these patients, and also helping to determine the severity of a patient's shock. And with this, they will use this assessment to help in determining support needs for these patients, whether it requires only inotropes or some form of mechanical circulatory support. And along with this, they will also help in determining patients' candidacy for MCS and whether or not there's a certain limit that we may take given patients' comorbidities or disease limiting what is able to be provided. And they will also help in identifying exit strategies for these patients if mechanical circulatory support is chosen to be deployed. And they will also help determine the type and facilitate MCS placement, and then help in determining where the patient will go following MCS deployment. And then at which point care will be taken over by either the CCU or the CTICU. And after all this, there will be clear documentation done in a consistent manner using a standardized, easy to use built-in note into Epic, which will allow for automated data retrieval and the tracking of our activations. So how will this team work? Well, when a patient's identified with a clinical concern for cardiogenic shock by anyone really caring for the patient, whether it's in the CCU, the floor, the cath lab, or really anywhere in the hospital, an initial assessment will be briefly performed by the cardiology fellow and or the attending. After which, if there's clear clinical concern for cardiogenic shock, they would begin an initial assessment with a stat echo, central venous stat if they're able to do so, and work towards getting urgent hemodynamic assessments of these patients. After which, if hemodynamics are consistent with cardiogenic shock, the shock team would then be activated to help in the management of these patients' care. And this would be the workflow that I would anticipate for a typical patient with cardiogenic shock. But there's obviously also going to be times when patients have more severe forms of shock upon presentation, those that have SCAI stage D or E shock, which may require immediate team activation prior to obtaining hemodynamics or the components of the initial assessment. And similarly, there also will be times when patients have much more borderline shock or question whether or not they are in shock, in which case conversations can be had with the advanced heart failure attending or with the CICU attending to discuss the need for shock team activation or for next levels of patient assessment and care. And what I want to really stress about this team is that this team is really designed to be a resource to improve the care of these complex patients. And we want as a team to be available to help in the management of these patients whenever there really is a clinical concern for cardiogenic shock. So please reach out to us as we get started. And we plan to get started relatively soon with an initial pilot phase during daytime hours, primarily within the Heart and Vascular Center to get this team up and running before we will expand to a 24/7 model and then expand throughout the York Street and SRC campuses. And because there currently remains little high quality data to inform precise treatments for cardiogenic shock, a key aspect of this team will be its ability to learn, evolve, and quickly adapt as we work towards improving the care of these patients. And this will come from frequent, careful review of the team's utilization and quality metrics, which will specifically look at the frequency in which the team is activated, the patient's shock stage at the time the team is activated, and the location from where these patients are coming from and where they are when the team is activated, so that we can optimize the utilization of this team. And we will also review the assessments that are being made of these cardiogenic shock patients for which the team is activated, and also look at the frequency in which we are using PA catheters and other mechanical circulatory support devices. And along with this, we'll be evaluating patient outcomes, looking at markers of end organ damage. We'll be looking at the therapies, at the patient's need for therapies such as mechanical ventilation and renal replacement therapy, as well as the length of stay and other outcomes such as mortality, all in an effort to optimize and improve the care of this complex patient population. And this team will also look to grow and evolve via the integration of external data and higher quality studies as they become available, such as these 5 listed ongoing studies into cardiogenic shock. And we will also integrate our own internal research on cardiogenic shock as this team grows within the health system, again, with the goal of improving the care of these complex patients. And with that, that is the rest of my end of my talk. Thank you, guys.
Alex, so fantastic development of a career-defining niche for yourself and fantastic training pathway. I was just wondering if you could speak to some of the lessons you've learned about the training pathway you've undertaken, and what are sort of the steps that you foresee that we need to develop as an institution in both the advanced fellow training as well as you transition to an attending level. What are some of the educational features that you think are going to be important for this team to develop most substantially?
Yeah, so I guess first, as far as the training pathway, my experiences, I think one of the first things was learning about this as a field of cardiology. And I think that there's now much more attention to it. And I think that now that we have a sort of a branch of the ACC that Dr. Miller is part of and stuff for cardiac intensive care, I think that that's definitely getting the word out and increasing the number of people who are training in this field. And I think along the way, as far as experiences that I've had, I think early on, because it was sort of a new field, a lot of this I had to look to leaders in the field to figure out what skill sets I needed to acquire to be a good cardiac intensivist. And now they're sort of defining and in the process of defining better training algorithms and defining criteria or specific skill sets that cardiac intensivists need to go into practice. And I think that that's where we are right now. And I think that for myself, I'm paying very close attention to what they're defining, but also trying to observe as much as I can in the CCU while I'm in the CCU to make sure I have that skill set along with my training. I think the other thing is that currently there don't exist many cardiac critical care specific training fellowships. Most of the critical care training comes from a general critical care fellowship that is pursued by other fields of medicine and other fields such as the emergency department. And within that, I think it's important to sort of carve out extra time in the cardiac ICUs and the cardiothoracic ICU to get more of that cardiac specific training. And I think also my personal experience in the amount of importance in caring for these cardiogenic shock patients specifically that occurs in the cath lab that led me to pursue additional training in interventional cardiology. So I think that was a big part of what I also enjoyed. And I'm forgetting the last part of your question.
Regarding the mechanisms or strategies to get a heterogeneous group of attendings currently in the CICU into on the same playing field, right, in terms of training in cardiogenic shock for the attending cohorts.
I'm sorry. So you mean how to get everyone sort of up to speed that's currently in the CCU? Yeah. So I think that as far as in the CCU itself, for general care of CCU patients, I think that now that we are having more and more cardiac specifically trained intensivists in the CCU, I think that they're creating much more sort of defined algorithms of how we treat patients and how we do standard critical care processes, which we have taken from both the ICU and the medical ICU and other ICUs, and that are fairly well defined, and bringing those into the CICU. And I think that those can be very easily followed by all of the current attendings that attend in the CCU. But for cardiogenic shock specifically, I think it's a very challenging area, just because there's not a lot of data to guide very specifically what the right thing is to do. And I think that right now we're at a point where we just need a multidisciplinary team that has expertise in sort of all angles of these patients' care. And I think that participating as part of that team is really going to be one of the key aspects of this. And also, as we learn from our own data, and we learn from what other studies are coming out, and we learn from what other centers are doing and reviewing the papers that come out, I think that that will really help improve other physicians' care of cardiogenic shock.
Okay, cool. No, Alex, that was phenomenal. I mean, I have to congratulate you on doing a talk as a fellow that I think it's even attending should look up to. It was amazingly well structured. The key question that always comes up is that super specialization in cardiology allows you to gain these skills that improve your understanding. You see the patients over and over again. But one of the challenges that you've encountered, there are so many hospitals in the country, there are so many centers in the nation where we not have that kind of super specialization that's unique to our large referral academic center. How do we make sure that the training that a general cardiologist gets in 2023 to 2030 reflects the learning that we have acquired from these advanced clinicians like yourself and Elliot?
Yeah. So as far as how do we get it out to sort of all of the cardiology fellows that are training, I think that one aspect of this is establishing sort of like a hub and spoke model, whereas these larger centers and have all of their affiliate centers are very intertwined and closely connected, so that they get experience with what's going on here and with these sort of like super subspecialized clinicians. But also in providing patients or experience for these other providers as far as like ICU level training, you mean? All right. So as far as providing additional ICU training for other hospitals, I think that other CICUs are starting to find additional ways to incorporate intensivists in the CCU. And that's something that we had showed in our the paper we had done on staffing models. We found that although there are mostly it's the large level 1 or the biggest CICUs that have these cardiac intensivists in them, other hospitals and other smaller hospitals are developing systems whereby they use other models, such as using a co-management model, as I mentioned, where they're incorporating intensivists into the CICU, from which I think fellows will get additional training in critical care at least.
So Alex, a couple of comments. First and foremost, to just follow up on Bill's comment. Really, congratulations, phenomenal talk. I think for our fellows and our trainees out there, the idea of having someone like yourself take a niche, develop it, and be willing and able, and hopefully soon to be expected, present an hour talk on a team that's driving the development is really wonderful to see. Really want to thank you for that. Secondly, it's culture, I guess. Culture beats strategy all the time, right? And so, I think changing the culture around a more kind of a closed to a closed unit to a program of physicians who are focused in this area. I think it's a challenge that we're working through right now. I think the concept of advancing a shock team, I think, and bringing especially to sometimes work computationally instead of in alignment, I think is also going to be an important culture shift. Thank you for leading that charge for us. My question relates to there's two questions. One is I'd like you to explore a little bit the observation that some studies, which I'm personally not surprised by, but I think I've had indications that as we engage with a cardiac intensivist model, we see actually perhaps a lower, better utilization of some advanced therapies. Some would have argued the opposite. I think, consider your thoughts about what's driving that and how we might study that phenomenon to gain insight. That's one question. The second question is related. Put my thumb a little bit on Elliot in the future here around the post-shock patients and how we develop pathway for those patients to continue to get the benefit of the expertise among critical intensivists in that vulnerable period post-shock into the ambulatory setting, and how you see that developing.
Gotcha.
Tough question.
All right. The first one again was.
Well, you can start with the second one.
Okay. The post-shock care. Yeah. So I think as far as the post-shock care, as far as managing care post-cardiogenic shock, I think that it is, at least right now, very heavily reliant on hemodynamic monitoring and monitoring very closely the early parameters of decline in patients, and also making sure that we're seeing improvement in hemodynamics, urine output, and that we're showing other markers that patients are improving. And I think in some way, the SCAI shock stages help with that a little bit, but they are somewhat broad. And I think that right now, there's not a lot of, there's a few papers out there that talk about hemodynamic monitoring post MCS and when to escalate and de-escalate devices. And I think that that does help inform somewhat, but it's not heavily data driven right now. And I think that's one of the challenges. So I think partially it's going to be our own experiences and seeing how these patients do as we gain more and more experience. But it's also drawing on what other institutions do, which largely mirrors on, I think, a lot more hemodynamic monitoring and very close fine tuning of all aspects of their care, which when we have more cardiac intensivists in the ICU, they see these patients much more frequently and they get more in tune with what those subtleties are. I think often it's very difficult to define one specific parameter that says things are getting drastically worse or drastically better unless it's already overtly obvious. So the subtleties in this, I think, are really, and having the experience in managing many of these patients over and over again is really what is going to improve post-cardiogenic shock care.
Transition to the ambulatory chronic setting patients, how do you get involved? What is the role of
as far as transitioning into the outpatient setting, I think that for a lot of these patients, a lot of that will come from involvement of whatever sort of subphenotype or phenotype these patients are displaying, as many patients recover in many different ways. Patients that come with an MI versus come in with chronic heart failure already following with an advanced heart failure physician, or patients that develop new SCAD or new peripartum cardiomyopathy. It's going to be a very different direction in which these patients are going. I think an involvement in those clinicians that will then see them in the outpatient setting when they are first coming into the CICU, when they're becoming more stabilized, will be very important in these patients' care. And I think that developing that continuity is very important. I think that's also one of the reasons, as far as my training, I've tried to spend more time in the outpatient setting for heart failure with some of the advanced heart failure providers to try and learn what more of these patients look like in the outpatient setting, so that when I see them in the inpatient setting and in the CICU, I have a better understanding of where they are and where we need to get them.
Evaluating use or non-use, and what parameters you're going to look at when you look at high acuity procedures, MCS, those things. What how do you evaluate the study, the decision process?
Yeah. So I think that was sort of one of the big things that we talked about as a group when we were evaluating or talking about this team coming together and how we should select the device, how we should make these decisions for patients. And I think that it really boils down to, and I think I showed it in one of my other slides, that there's not a lot of good data to say, if this, do that. And because of that, it really relies on expertise from the physicians who are implanting devices, and expertise from the clinicians or the physicians that are managing these patients in the cath lab, in the cardiac ICU after they're placed. And I think that that really plays a lot into this device selection. And because of that, it really requires sort of a group discussion and a group discussion of all of the factors that are being weighed in and what the goals of these devices are. And I think that's why right now, at least, there's no real good specific algorithm of if this, do that for a specific device. And because of that, it's going to really rely on a team mentality at this point, at least until we can incorporate additional high quality data.
Good, great talk. Really appreciate it. Couple of thoughts. They're a little scattered, and feel free to answer one or none. But the first is on the epidemiologic data that you're showing in terms of reducing the mortality associated with shock while the rates of shock are increasing, looks to me to be a classic Will Rogers phenomena, where we're increasing the use of the diagnosis of shock without necessarily seeing the same types of patients in those buckets. So it's something which probably has been commented on before. In terms of the utilization of the shock team, again, kudos to the team for pulling together something that's been a long time coming, and it's great to see it in fruition. Having reviewed the protocols, and I think this is a little bit close to what Eric was talking about, it is not prescriptive, right? And I think the good part about getting everybody together is that there'll be robust conversations. The bad part about not having a prescriptive approach is that the loudest person will win. And particularly when you're talking about people with different expertise and different levels of comfort with critical care. So I think that's where, again, I would propose being more prescriptive, but dynamic, as you said, with the learning healthcare system would be the way to go, as opposed to starting by whoever's talking most loudly and demanding a CP55 or whatever hell we're going to use. Because there is this complete paradox with, we've never shown in a randomized fashion that invasive monitoring works or that mechanical circulatory devices work. Yet in observational data, we're seeing these pretty significant reductions in shock mortality. And so, I think the more we can do, the better. And then the third piece, and this is more probably for Elliot, is really we need to be in this clinical trial space. Right. And, with Carlos de Villa and, we've reached out to the Impella team. We have a complicated relationship with that team, or at least the manufacturers. But we really need to be part of that solution if we're putting holes in their proposals.
All right. So question number one was about the rates of rising shock and the sort of stable mortality that we're seeing. So I think a lot, at least in my experience or my opinion of looking at this data, a lot of the large registry data is very challenging. And it's mostly challenging to interpret just because how patients with shock are defined. And I think that there's been various definitions of shock that are utilized in these different studies. And it's also very difficult from registries to identify when exactly a patient is in shock, such as like a stage B shock patient. It's very challenging to pull out of a registry because they don't have very hard parameters of a lactate. There's also many forms of mixed shock and other things that I think overall make the actual diagnosis of cardiogenic shock very, very challenging to tease out. So in a lot of ways, I think that we are sort of left looking at large registry data that we do have. But my general sense, at least, is that the mortality is similarly stagnant, although we are seeing a rise in cases. The second question was about the shock team and the use of protocols. So we did, as I mentioned, talked about this quite a bit. And I do see the impact of obviously there being the loudest person in the room phenomenon. And I think a lot of what we're trying to do with this team initially is really be a resource very early on that everyone is freely welcome to use and to utilize. And that when this team starts to get together, I think looking at how it's being used and looking at what we're doing and looking at our sort of team metrics is really what is going to help drive in developing a specific protocol or something closer to having a more algorithmic approach to these patients. But right now, due to the lack of data, I think it's very challenging. And we also didn't want people to feel forced into doing something they weren't comfortable with. And I think that that's one of the challenges that we are definitely going to have to work through as a group. But right now, I think taking a more open approach, at least discussing this as sort of the working group that we had, was the way that we thought we're looking at tackling this initially and then adapting as need be. And then I'm forgetting the third question now. Sorry. Randomized trials, yes. So definitely, we definitely need to be involved in these randomized trials, and we are already starting to collect data from patients retrospectively, and as this shock team gets going, start to enroll and look at the outcomes of these patients as we develop a shock team, and then through publications. And I've already talked with Dr. Davila a bit, sort of working on getting into the part of these registries and running clinical trials with them, but also being able to run hopefully pragmatic trials within our own hospital system itself, given we are a quite large hospital system.
Yeah, congratulations, Eric. Congratulations to Alex on your start of your career and developing this nice talk and everything. You summarized nicely how the CCU has changed over the last 50 years to something that was quite narrow to something broader, and you're addressing that very well. One of the things kind of from a system standpoint, if you build it, they will come. This is going to create a big demand. And how is this going to influence not only how cardiology works, but in terms of the relationship with the MICU and the other ICUs, which, if you look at the MICU, how huge it is, every time they grow, it just fills up. And how is that going to develop, within cardiology?
So, I think that our relationship and collaboration with the MICU is hopefully only going to further grow. We're now doing studies with combinations of, such as Dr. Miller, our cardiac intensivists working with the MICU attendings to work on projects looking at extubation using echo parameters and looking at using BiPAP or high flow and its impact on extubating patients that have heart failure. So I think, one, there's going to be much more collaboration between the CICU providers and the MICU providers and other intensivist providers throughout the hospital, which I think will really help in a lot of ways triage these patients, and to some extent, as everyone becomes sort of more familiar with what patients are best served in what location. I think that will hopefully also help lead to better patient placement, and that patients that have more severe cardiogenic phenotypes will end up more in the CCU, and more of those more septic patients that don't have any cardiac disease will end up more in the medical ICU. So I'm hoping that in one part, there's going to be some sort of rearrangement of where patients are in the hospital. I think that honestly in itself would be one of the best things that could happen, because it will probably lead to decreased lengths of stay as you have sort of the right person taking care of the right patient in the right place. Stop sharing. Thank you. Yeah, I'm a little short, but thank you. Thanks. Yeah.
Coordinate the PA catheter back